don't know if anyone understands that these are not planned. They're just like literally random shit that like we start talking about. So it was someone, because we were talking about fistulas, and so Gallstone Ileus. So someone brought up, so the D in the Frenz mnemonic for fistulas is distal obstruction, and one of the examples of that would be Gallstone Ileus. So it's one of those highly tested, rarely seen topics, which we always talk about, they love. Pancreatic neuroendocrine tumors, never see it. We actually tested for one recently. Never see it in real life, but always tested. Gallstone Ileus, I've had a handful of them. Again, they're interesting cases. So Frenz mnemonic, distal obstruction, because of the stone that's in the GI tract. So someone comes in with a bowel obstruction, and you get a scan, and all of a sudden you see an obstructing lesion, which turns out to be gallstone. So what though, because that's all fine and dandy, that just sounds great, and it's fun to talk about. What's the bigger issue?
Digestive, like enzymes not being present or anything?
No. So, okay, at its core, what we're talking about here is this is stomach, again, stomach, duo, jejunum, and then say terminal ileum. Okay, you have this big old gallstone that's caused a distal obstruction. And this patient presents to the ER with nausea, vomiting, and abdominal pain. They're found to have a small bowel obstruction. And then we're like, oh no, it is a gallstone. That is like the least of my worries. What's the bigger problem? Where did it come from, obviously? The gallbladder, okay? So you got this gallbladder over here, okay? And you had this big stone, because this is not gravel, this is not sludge. Oh. This is a big stone, okay? So you have this big old nasty stone in the gallbladder, and this is the liver. And then this is the cystic duct, and then this is the common hepatic duct, and then this is the bile duct, and this is the pancreas, and then like we just said, it all comes over here real nice. How did this get over to here?
It eroded.
Speaking of fistulas.
Yeah, it could have
The wall.
This was such a big stone, and this is what happens. When you have the big stone, the duo sometimes gets stuck. I don't know if you guys have seen a laparoscopic cholecystectomy or robotic cholecystectomy where the duo is like stuck up on the gallbladder. Because this is causing inflammation of the gallbladder. Again, Frenz mnemonic, inflammation. And that inflammation here all of a sudden starts rubbing on the duo, and then all of a sudden you get a choleduodenal fistula. And then dink, this stone goes in here, and it goes ding, 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 boom, bing, bong, bing, boo, until it gets stuck. What do I do here? Just do a little bowel resection, get rid of that, and put this back together. No problem in the world. Everything's good. Where's the bigger problem? Here. So the textbook answer, this actually was one of my oral board questions, because this is, again, how classically tested this is. The answer is to leave this alone and then get your hepatobiliary guy to take a look, okay? Because then there's another important concept, which is very similar to this exact situation with fistulas, is what's it called when this is causing a common bile duct obstruction here? Yeah, this is called a Maritzi syndrome. Maritzi syndrome. So I used to think, oh, no big deal. There's a little stone pushing on the bile duct, like when I was an intern and stuff. Well, this is a huge problem because there's different, I don't know it off the top of my head, but there's a whole classification system for Maritzi syndrome. Pull it up. And the issue is, what can happen then? So the big stone's pushing on the bile duct, causing a hyperbilirubinemia and a bile duct obstruction. Same thing here. What can happen?
Another obstruction. Can you get bowel leak?
What has been this topic that we've been talking about?
Like another fistula.
Another fistula. So the gallbladder fistulizes to the common bile duct. So now it's just like here. We have a huge hole in the duo here. And over here now we have a huge hole in the common bile duct. This is just catastrophic stuff. So Maritzi is a big deal. What are the different types?
There's type 1, 1 through 5. 1 is external compression of the common hepatic duct.
Yeah, so that's what I always thought it just was. Okay, there's something giving a little push, right? A little compression. No big deal.
Yeah, just impacts at the neck.
Okay.
And then 2, fistula involves less than 1/3 of the circumference of the common bile duct.
So like you're talking a little bit of the CBD.
3 is between.
But now we're in fistula land. You know what I'm saying? Again, so that's why this is a problem. 1 is what I thought it always was. But then I was unaware when I was a junior level resident of like, holy crap, this could be a big, big problem. So what's 3? Probably
3
more.
is between 1/3 and 2/3.
Okay, sure.
And then 4 is entire wall of common bile duct.
That's it.
Destruction of common wall. And then type 5 is cholecystoenteric fistula together with any other type of MS.
Okay. So yeah, again, a Maritzi can be catastrophic. So who would I call to deal with all this stuff? Because I ain't doing any of that. Yeah, so my HPB friend, my hepatobiliary surgeon, because this is just very complex, may need a complex reconstruction. What's the reconstruction that we would do if, say, we did have maybe an injury to the bile duct or something else here? So this is the common hepatic duct here, right hepatic, left hepatic. What's the reconstruction?
Can you anastomose the common?
Yeah, so an HJ. Hepatico-jejunostomy. So I pull my loop up and I anastomose it to the hepatic, which is before the common. And I get rid of the gallbladder.